So in a hospital system, even though we work in a system, nurses are either individually or collectively considered responsible for the skin, because there are not other folks around that are really keen on pressure injury prevention. And so when a patient develops a pressure injury, you can look at the nursing care provided, but sometimes, as we've really already talked about through the previous two sessions, nurses don't always have a lot of ability to directly influence that care. Sometimes they have orders not to turn the patient. We've talked about that. There is a set of doctors that seem to think that if they fixed the body organ they operated on, so for example, the heart or the brain, the skin will just take care of itself, and there's really no need for them to look at what's going on with the skin because they did they did their work. There can be a high turnover of staff, and by the time that you get them trained, they may decide that critical care isn't really what they want to do. And then, as we've talked about, particularly with Kathleen Bowman in the last session, there's fear in moving these patients, and no one wants to be responsible to cost a patient his life. And so the decision is often made, well, if the skin suffers from me not turning the patient, at least I saved their life. So you can see those variables playing into the story of the high rate of pressure injuries in the critically ill. I was interested in a recently published study that looked at pressure injury claims in the hospital setting, looked at vascular compromise, and looked at retained foreign bodies, and to see what nurses' roles were in those claims, because those are pretty common claims that involve nurses. And pressure injuries was the most common claim that involved a nurse. Vascular compromise was not as common to be a nursing, at least a critical care nursing issue. And foreign bodies, of course, tended to be in the operating room. Now the study, in case you're new to ICU, new to nursing, by the way, welcome on board if you are. You might not have ever heard that phrase, decubitus ulcer, so I do want you to know that that's an old term for pressure injury. When they drilled down a little bit into the study, they were looking at the actual legal claims. So the way this works is a patient's family goes to an attorney to report an abnormal event that they felt was preventable. And the attorney looks at the record, and if the attorney sees something that strikes him or her that may indeed have been preventable, they send it to an expert. The expert reviews it and then generally writes up some kind of evaluation of the care provided and the opinions of the care. So those opinions get expressed in fairly common language, and that's what's on the graphic that you're looking at, is what did the attorneys decide to file a claim on based on what their experts said. And you can see how pressure injury could easily be the claim and these be the 5 opinions. So the first opinion was failure to monitor the patient. So if you've got a patient with a low Braden score and you can't turn them and you can't see the skin, how are you monitoring the skin? How can the skin be described as intact and then, whoa, all of a sudden there's an unstageable pressure injury? Was there something that somebody missed prior to that? And if they missed that, could that be considered an improper patient assessment? Or maybe somebody documented that there was a skin tear on the buttocks. I don't know how you get a skin tear on the buttocks because it's pretty hard to abrade the buttocks in a hospital bed. And maybe that was actually a pressure injury that somebody missed and misdiagnosed. So then what's the policy in the hospital say about notification of the wound care staff, upticking the bed, increasing the frequency of turning, using a turning team, getting somebody in to help you? What are the policies? Did you follow them? Now, if you didn't follow them, you probably have to have a pretty good reason not to follow them. They're not an absolute rule. There are policies that sometimes cannot be followed, but be sure you're clear in your documentation about why you couldn't follow a policy. Probably one of the more common things that I see in claims against ICU nurses is I can't figure out who communicated with who. Who let anybody know? Did the nurse notify the doctor to get a wound consult? And when that was done, was the doctor out of the picture from that time on? How come in the discharge summary of the patient leaving your facility, there's nothing documented about a pressure injury, yet I know it's there? That's a communication piece, and you really need to be sure that your documentation supports that you did the right things. Of course, that's all under the umbrella of patient safety, because hospital-acquired conditions are a patient safety issue, and pressure injury development is one of those. So one of the statements certainly made by many of the experts is failure to keep the patient safe during the ICU stay. And it's not just falls and adverse drug events. Pressure injuries actually fit in that same bucket of patient safety issues. Well, the last section I want to talk to you about is the price. Pressure injuries are not cheap. They're not cheap on many levels. They're pretty expensive for the patient as far as lost time from work, going to multiple outpatient wound centers for debridements. Sometimes the patients need flaps and diverting colostomies just to manage these wounds. And so the price goes on and on and on. There have been some folks that have done some estimates on the cost of pressure injuries per stage. And I'm going to do a little math with you. You're an ICU nurse. I know you're good at math, so this won't be hard for you to figure out. So Dr. Padula did an estimate and published his work on what does it cost a hospital when a stage 1 or stage 2 develops. What's it cost for the care of the patient, for the assessments of the patient, for the topical treatment of the patient? And he came up with about $2,700 per patient for this wound. Now that seems high, doesn't it? But I can refer you to his article. I put it there for you to see the actual material of how he figured that cost out, and his prices are spot on. He includes a lot of things that you may think of as just part of routine care. Let's jump up to the more expensive ones though. When you have a full thickness ulcer, stage 3, stage 4, you get up into the thousands of dollars. $71,000 to $127,000 per ulcer. Now this includes debridements, negative pressure therapy, sometimes amputation, diverting colostomy, all of that care that's necessary to bring the patient from the point of ulceration to the point of complete healing. Wow, it's getting high, isn't it? Yeah, and this is per patient. So I wanted to figure out one time, what's it costing our hospital for pressure injury prevention and treatment? So I did a little math. What I wanted to figure out was, over the course of a year, what did this whole thing cost us? Because remember, we're not getting reimbursed for these conditions when they happen on our watch. So this is money lost or money spent, one way or the other. We're either buying or renting the negative pressure device or the enzymatic debrider or the dressings and not getting reimbursed for them, or paying out lots of money for additional bed rental and so forth. So it gets pretty high. So here's what I did. The current rate of pressure injury in our hospital was 2.5%. Now that doesn't mean anything unless you have an actual number that you're dealing with. So what I decided to do was look at the number of annual admissions. This is a few years back, of people coming into our hospital. So I did not eliminate OB and acute psychiatry. I couldn't sort that out, but I got that number off of some public data, and our number was a little over 24,000. So I knew that 2.5% was our hospital pressure injury rate. So what's 2.5% of 24,557? I came up with a number, and then I said, all right, the majority of the injuries in our hospital were stage 1s and 2s. And so I took the 2% of the 2.5% and said, okay, let's call those the stage 1s and 2s, because that was probably accurate. And I multiplied 491, which is 2% of 24,557, times the number of 2,771, and I get 1,000,003 for the stage 1s and 2s. Then I split 122, which is half a percent, of 24,557, and said, okay, 61 of those were the less expensive, 71,000, and 61 of those were the more expensive, 127,000. You can see the total bill was over 13 million. That's money we either paid out or didn't receive back. Does that seem high? Yeah, it seemed high to me, because we don't see the numbers. We're dealing with people, and in intensive care, you're dealing with folks for a fairly short amount of time. You know, the average length of stay is not too many days, but these people that were injured during the stay in critical care go on to require lots and lots of services. So I want to turn to another expert in the field of the economics of pressure injuries. I'm going to ask Dr. Padula to join us to tell us the story of what the cost is at a national level. I think you'll find these numbers pretty stunning.